Okay, perfect. Um, so hope everyone can see everything. Feel free to join the Socrative. I'll launch it now, and we might do some questions at the beginning. Today, we're just going to go over briefly population health and especially some of the statistics that come up and how to quantify risk, both in the context of the AKT, so you can have multiple choice, and sometimes they can throw people off because they're not really expecting that in the written paper. But there are also some OSCE stations that could come up. Again, it's unlikely, maybe a bit mean, but they have been a bit dodgy in the past on the stations. So it's always best to just prepare, and then if it doesn't come up, then it's all better. So the room name is Osmi. Um, okay. Sorry, has anyone joined the room? If someone could just unmute and let me know.
I have, I think.
Okay, and can you see any questions?
No, it says waiting for the next activity to begin.
Okay, fine. Okay, fine. So there's a question up there now, I hope. Um, I'll just give you guys a second to join. Feel free to just guess if you're not sure. We'll go through the answers. I'll just wait for a couple more of you to answer. Okay, perfect. So most of you have answered, and you should have gotten the answer in your feedback. We'll just do one more, and then I'm going to talk through all of these measures. Okay, perfect. So thank you very much. Sorry to throw you in the deep end, but this is a sense of some of the questions that could come up related to diagnostic tests and especially screening. So this can come up in both the AKT paper and your LabMed paper. Um, so in terms of, let's start with sensitivity and specificity, and then we'll go back to the first question, which also touched on positive and negative predictive values. So you can think of sensitivity in two ways. Firstly, for any multiple choice, it's nice to just remember a formula in case you need to calculate a value. And so it helps me to remember it as the true positive rate. So sensitivity is true positive. And so to calculate, you're doing the true positives over the true positives and the false negatives. So essentially, in anyone who actually has the disease, who of those are getting a correct positive result? So that's for if you're doing a calculation. And then in terms of explaining sensitivity to a patient, I like to remember, for example, everyone on the ward says that D dimer is a really sensitive test for PE or thrombosis, DVT. And essentially it means that good at it's good for ruling things out. So if you get a negative, it's very likely that that person won't have that disease. Essentially, in anyone who truly has the condition, so the denominator, true positives plus false negatives, it's able to identify a lot of those. And then, so the opposite is true for specificity. So again, if you're calculating, you can remember it as the true negative rate. So this is true negatives over the total number of people who truly don't have the disease. So that's true negatives and false positives. Um, and specificity is more like similar to how you'd use the word in English. It's just if a test is specific, it's good at identifying those that actually don't have the condition. Um, just as a memory aid, you can remember spin, so specific to rule in, and snout, sensitive, or like SN, to rule out something. Rarely they can give you something that looks like this graph on the top right. So it's nothing to get too confused about. Essentially, we've got the true positives on the red curve, so someone who truly has the disease, and true negatives on the left, so the blue curve, people who don't have the disease. A, B, and C, so these vertical lines are where we can have a cutoff value. So, for example, if we say, someone gets a 5 on this test means they do have the disease. Less than 5, they don't have the disease. So let's say B is like our compromise threshold. If we're moving from B to A, so moving our threshold sort of to the left or lower, we're completely eliminating false negatives. Does that make sense? So we're essentially making the test more sensitive, not allowing anyone that has the disease to get a negative result. Vice versa is true for moving from B to A. We're eliminating false positives, essentially making the test more specific. So someone who doesn't have that disease will for sure not get a positive result. Okay, some other test-related evaluation metrics are accuracy and precision. Um, you can think of accuracy as sort of how um, close the test value is to the real value. So essentially how close to the bullseye on the target the result is. Precision is more about how close together, the arrows are falling on the target. Um, so things can be precise but not accurate. So if they're close together but far away from the true value. And things can also be accurate but not precise. So hitting sort of around the true value but very different to each other. Okay. Then these next metrics are a bit more complicated and they can interact with each other. So let's talk about positive and negative predictive values first. These are, so all of them, sensitivity, specificity, PPV, NPV, are related to a diagnostic test. But sensitivity and specificity are sort of inherent to the test itself, whereas PPV and NPV can be modified by other factors, for example, the disease prevalence, and I'll talk about that in a second. Um, Positive predictive value is essentially what it says on the tin. If you get a positive result, what's the likelihood that you really do have the disease? So you're dividing the true positives over the total positives, which is going to be true positives and false positives. Okay, and the negative predicted value is sort of the opposite. The probability that if I get a negative result, I for real don't have the disease. So true negatives divided by the total number of negatives. Again, true negatives plus false negatives. Um, we'll discuss now incidence and prevalence and the difference between those. You can be asked about the definitions of those two, and then how prevalence can affect PPV. So incidence is again, sort of like how we use it in English, like how many incidents are there? So the number of new cases. But the important thing is the denominator, which is the number of people at risk. This is all over a unit of time. So, for example, the incidence in a year is the number of new cases of, for example, pneumonia over the year in that population. And when I say people at risk, we need to remove anyone who's already been diagnosed. They can try to trick you in the question by giving you let's say at the start of the year, 500 people had already had a diagnosis of pneumonia in a population of 5,000, and then they'll give you the number of new cases over the new year, and you have to remove those original 500. Um, Prevalence is the number of existing cases in a total population, a total number of people in the population, and this is at a specific point in time. Um, so that next bullet point where it says the shorter the duration of the disease, the more close prevalence is to incidence. So if you have a disease that lasts a very long time, so a chronic condition like heart failure, the incidence might be low, so we might have only 5 new cases a year, but the prevalence keeps increasing because those people are living for longer with the disease. Whereas for things like the common cold, they're only lasting a few days. And so if we have, say, 20 cases in a year, it's probably likely that there's about 20 people in the population that have a cold at the current time. Um, and then how does prevalence affect PPV and NPV? Essentially, if we think about it as a disease with low prevalence, you're essentially testing a healthy population. This means that the majority of the population doesn't have the disease. And so even if the test is highly accurate, then so even if the test has a low false positive rate, essentially, you're going to generate more false positives just because there's so many more people who truly don't have the disease. Does that make sense? The inverse is true for if we reduce the prevalence. The same thing. So if we're in a healthy population, the negative predictive value is high just because the number of people who don't have the disease, so true negatives, is high. Okay. I appreciate these are all hard to word and discuss with patients. If it's helpful, we'll do questions first, and then we'll look through some example OSCE stations where we can talk about how we're going to tell a patient things like this and explain the values to them. Um, Before we move on to some more questions, this curve on the right is a receiver operating curve. You don't need to know it in huge amounts of detail, but in case they have it in a question on your multiple choice papers, just to understand what's going on, we're plotting the true positive rate over the false positive rate. Um, it's a random classifier, so something that just randomly gives out true positives versus, or like positives versus negatives, is this dashed line in the middle with like gradient one. And for that, the value of AUC, area under the curve, is 0.5. The most accurate test is that point in the top left corner where the true positive rate is 1 and the false positive rate is 0. Obviously, a real test that we use in practice will be somewhere between these. If we increase the sort of gradient of the curve, we're moving to a better classifier, to something with a higher true positive rate, whereas something lower down. They could give you two curves and ask you to compare, or like ask you which would be a better diagnostic test for a disease, for example. Okay, just going to check what's on the next slide. It might be that we need to do some more questions. Oh, okay, let's discuss screening first. So in the lab med syllabus, you might have seen a small line that discusses how you need to know like the cancer screening programs that exist in the UK. There are three. It's useful to know the ages, how often they have to come for screening, and what the initial screening test is. Unfortunately, these just have to be memorized, but it's gotten slightly easier. So cervical cancer, you might have known before they used to do it every 3 years and then every 5 years, depending on age. Now it's just every 5 years for all women between 25 and 64. For breast cancer, a mammogram every 3 years, and we start at age 50 because below age 50, the breast tissue is a bit denser and mammogram isn't as accurate. And for colorectal cancer, it's a FIT test every 2 years from the age of 50 to 74. I've written the pathway for cervical, so like smear testing, and what happens after the first test is just a HPV test, looking for high-risk HPV variants. After that, you'll move on to cytology and then referral to colposcopy. Um, it's not hugely important to remember, how often or sorry, how frequently they have to come back after an abnormal result. But just in case, if you want to read off on it, just in case they put out a rogue question, then I've written the pathway. Fine. Okay. Let's go back to the Socrates, if that's all right. There's a couple more questions on the concept that we just talked through. Um, these are a bit more mathsy, so they might take a second. I'm going to go back to the slide with the formulae for specificity, etc. And sorry, just in case anyone hasn't joined and wants to join, the code for the room name is OSME, so OSME. Just waiting for a couple more of you to finish. No worries if you're not sure, you can just click an answer. And I'll send out the questions with the slides. Okay, perfect. So I've got most of the answers. I'm going to move on. So here, this is positive predictive value. So the formula's on the screen, but we're looking at everyone who's got a positive result, which is the 56 and 12. And of these, who are the true positives? So it's the people with confirmed asthma. So the first set, so 56 over 56 plus 12. Okay. This is the same test, and it's asking now for sensitivity. Okay, lovely. So most of you've answered. Again, I'll just explain. So we're looking at sensitivity, which is so the denominator of sensitivity, given that its true positive rate is the total number of people who truly have the disease. And in this case, it's just 100 because it's the ones with confirmed asthma with the original test. Of these, the true positives are 56. So 56 over 100, 56%. Okay, apologies. This next one, we can wait until we've done the next section. But before we do the next section, I'm just going to go through some OSCE stations that could, again, unlikely, don't be stressed, but just in case it does come up. So this first one is a bit more simple. So Mr. Patel, 60 years old, has received an invitation for the NHS bowel screening program, bowel cancer screening program, and speaks to his GP. So he's asking the following questions when you chat to him. He's saying, what's the point of screening if I feel fine? Secondly, if the test is positive, does that mean I've got cancer? And he's also asking, if I have a negative result, do I not have cancer? For sure. Okay. So just a second for you guys to think, but it's the concepts that we just discussed before. Essentially, we're looking at positive and negative predictive values. All right, so for the first one, he's asking about what's the point of screening if he feels fine, he has no symptoms. And here we need to understand the principles of screening itself. Essentially, all screening happens in asymptomatic individuals. If they've got symptoms, we're going to be investigating them, as per typical pathways. But population level screening is by nature in people who don't have anything to present with. And the purpose of this is to detect cancers at their earlier stages or at their most treatable stages, essentially. Um, if he asks or if he pushes, he might say, what's the point of doing this in terms of, are there any negatives? And you might have to discuss the positives and negatives of screening itself. Um, there are four key negatives of screening. Firstly, the false negatives. So someone could have a false sense of reassurance, and if we say bowel cancer screenings every 2 years, then they might feel they might have symptoms, but because they've got that negative result, they won't present until their next appointment. Um, Secondly, false positives, where people get a positive result, but they don't have the disease and they feel anxious about it, things like that. Thirdly, overdiagnosis. So this is where even if they do have the cancer, it wouldn't really have been picked up and it wouldn't have been causing any problems at this current stage. So you're treating something that wouldn't really have been an issue in the first place. And then fourthly, the adverse effects of the screening test themselves. So if he has a positive fit test, which is the first stage of the bowel cancer program, as we said before, he's going to go on to have a colonoscopy. These can cause things like bleeding, infection. The risks are low, but they are still there. So four key risks of screening, and obviously the positives of screening are to detect cases earlier and pick things up that could cause problems. All right, okay. His second question, if the test is positive, does that mean I've got cancer? Um, so here we have to explain that screening isn't diagnostic, it's just an indication for further investigation, essentially. Um, so the first stage is fit, and we know what would happen or what other things can cause a positive fit test that aren't cancer, right? So you can explain those to him. Things like hemorrhoids, IBD, polyps that are bleeding. And obviously you have to explain that cancer can be a cause as well at this stage. Um, and that he needs a colonoscopy if the test is positive, as in explain the next stage. Okay. And then asking whether a negative result means that he's definitely clear. So obviously, screening test, the first stage of screening, you want it to be highly sensitive. So you want it to be a rule out test. But that doesn't mean that tests are 100% sensitive, right? So if someone has a negative result, there is a small chance that they do still have, essentially that it's a false negative, that they do have the cancer. And so at this stage, you can safety net him. If he has a negative result, and he feels, change in bowel habit, bloating, weight loss, unexplained weight loss, unexplained blood in the stool, then he needs to present earlier than his next screening appointment. that make sense? So just addressing each of his concerns in tow. At the start of this station, obviously, and the same for all of these stations that I'm going to talk about, ice the patient. I always forget to do this in stations that aren't a history, but just in any OSCE station, ice them at the beginning so you understand what they want. Secondly, before you give information to someone in this sense, where you're explaining values or concepts that they might not know before, consent them in the sense that ask them how much they want to know, if they're okay with numbers, just to make them feel happy. Then at the end, ask them to repeat back to you what you've explained, but phrase it in a way like just to make sure that I've explained it clearly to you. Could you tell me what I've just said? Um, and this ensures that, they've understood, but doesn't make them feel disrespected. All right, okay. This next one is a bit more complex and there's some math. So I'll read the station. You guys can have a go at thinking about like what numbers you need to talk to her about. And then we'll discuss firstly the calculation and then secondly the framework in terms of like how we need to explain it to her. So Mrs. Okafor, 52-year-old female, has been recalled after a routine like screening mammogram and she is sad. So she's been told that the screening test is abnormal and she thinks she must have breast cancer. And the information that's been given to you outside the station is the sensitivity for this test, mammograms, is about 85%. The specificity is 90%, and the prevalence in this age group is about 1%. So think about what we discussed before, which um, measures are affected by, or essentially which measure you need to talk to her about. She's got a positive result, and how prevalence can affect this, and so how you need to calculate this. Okay. Sorry, I appreciate it's not much time, but I just want to make sure we finish on time. Um, so we're thinking about what she's worried about. She's got an abnormal test, so a positive result, and she's worried about if she has the condition, truly has the condition. So we're looking at positive predictive value. So given that she's got a positive test, what's the likelihood that she really has breast cancer? Okay, and when you're explaining it to a patient or whether you're calculating it for yourself, we can start with a large population just to make things easier for ourselves. So I'm going to start with 1,000 patients, let's say, who are participating in the screening program. Um, if 1,000 patients are screened and 1% have the condition, so the prevalence is 1%, then let's say 10 people have breast cancer and 990 people don't. Hopefully it's all making sense so far. Please do put things in the chat if you're not sure. Fine. So 10 people with breast cancer, 990 people without breast cancer. No breast cancer. Um, then let's look at the sensitivity, which is the true positive rate. So of the people that have breast cancer, 10, then 8.5 have a true positive. Let's say like 8 to 9. And then if we look at the true negative rate, so specificity, we're looking at the people who don't have breast cancer, so 990. And of those, the 90% means that it's like 891 because 10%, 99, will get a false positive. Okay. Then if we add together the people who have the positive result, so this is the people who have a true positive, which I said was 8 to 9, and the people who have a false positive, which is 99. Okay, so 9 plus 99 is 108. Okay, so 108 people have received a positive result of our original population of what we said was 1,000. Okay, And then if we remember the formula for positive predictive value, this is true positives, which is 8 or 9. Let's say 9 over the people who've received a positive result, 108. Okay. Um, Let me just calculate this. It will be about 10%. Fine. So this is 8%, the positive predictive value. Okay. So for Mrs. Okafor, the chance that her positive result means that she has breast cancer is 8%. So less than 10% chance that she really has breast cancer following the screening program. Um, does that make sense? So we've talked through the numbers to her. For that final step, you can explain it in terms of like, if 100 people were in your position and got your result, 8 of those would really have breast cancer. So that's the maths aspect. And then in terms of explaining it to her, again, ice her at the beginning, understand why she's worried. At this point, the actor might reveal that there's a family history or something like that. And as I said, ask consent to talk through the numbers, all the jargon with her. Explain the percentages like we just talked through. Um, and then explain, the point of the screening again. This is why we do further tests before drawing conclusions, the fact that there's only really an 8% chance that you have breast cancer. Um, then, as we did with the colonoscopy, explaining the next step. So post mammogram, she'll be referred to the breast cancer clinic. She might have to do a different mammogram from a different view, maybe an ultrasound scan, and potentially a biopsy, depending on what they found. Finally, check if they've understood with that framing that we talked about before, and ask if they have any other questions. I think a trip up that people might encounter in the station is to give them false hope. So obviously none of you are going to say, if she says, oh, so that means I don't have breast cancer, you're not going to agree with her. But don't be misled into saying, oh, that you're probably fine. Don't worry about it until your next appointment. The chances are very slim because an 8% chance is still not negligible. Don't collude with the patient in that sense. Um, It's also, this is a useful case to think about, screening itself. Overall screening or population level screening is going to return a lot of false positives, um, just because the positive predictor value is quite low. But that's why we're going to do further tests after. Okay, fine. I'm going to not discuss this slide, but it's sort of hidden in your epidemiology teaching on Canvas. And I think there was a question on our AKT that asked about a specific like data source. So just have a read through what's available with each one. So mortality statistics, obviously it's about death, cause of death. Hospital episode statistics about cases that are coded in hospital, like sort of on EPR. Cancer registration is specifically for oncology cases. Primary care data is like the system that we use in GPs, so in Oxfordshire, like EMIS. And vital statistics is any like general things, births, deaths, marriages. Okay. Moving on to study design, and then we've got a couple of questions. We can split these into first experimental and observational. Usually they'll give you a study and you have to identify what type it is, or they'll give you a study with results and you have to quantify the risk. And we'll talk about those calculations later. If we split first into experimental and observational, it's really obvious what an experimental study is, and that they're going to be splitting a population into groups, and then one group will experience an intervention that the study people are going to give. And so in this case, the exposure is the intervention, and it should reduce the risk of whatever you're measuring. The most important one is the randomized control trial, where you're giving an intervention to individuals rather than the cluster trial, which is less frequent, but you're giving an intervention to like a group. Okay, then differentiating between the different types of observational studies. Um, in a case control study, you're picking people with cases. So you're picking cases and controls. So cases are people that have a disease, controls are people that don't have the disease, and you're going back in time looking at whether they experienced a certain exposure. So that can be things like, whether they smoked, whether they took a certain drug in the past, whether they had a specific occupation, for example. Um, Cohort studies are similar, but now you're sort of starting with the exposure. So you're looking at smokers versus non-smokers, following them up and seeing whether they developed heart disease or not, for instance. Does that make sense? Um, and a cross-sectional study is different from these two in that you're taking a snapshot and looking at whether the exposure happened at a specific point in time. It's hard to tell whether, with these studies, it's hard to tell sort of what came first. You assume that the exposure came first and then the outcome, but because you're doing it at a snapshot, it's hard to tell. Um, and ecological studies are sort of observational, you're looking at a whole group. The thing to remember here that could come up in the exam is this ecological fallacy, essentially inferring that just, sorry, or like misinterpreting a conclusion about a population and attributing it to individuals. So, for example, if we look at, let's say, high income countries, and the fact that, people who have sedentary occupations go on to develop hypertension as a population, that doesn't mean that a single individual who has a sedentary job has hypertension. Um, Things like this, it's obvious, like to describe what comes up in the question, but the question might give you the reverse and ask you to identify what kind of bias or fallacy is going on. Okay. Then thinking about bias and confounding. Um, let's talk about confounding first, since it's a bit more clear. A confounding factor is a variable that's independently associated with an exposure and outcome. And the way to think about this, if it comes up, is think about the pathway from exposure to outcome. So, from, for example, smoking to vascular disease. If the confounder does not lie on that line between exposure and outcome, then it's something separate. Does that make sense? So if it's not part of the mechanism that leads from exposure to outcome, then it's something else. Um, then the different types of biases. I think the key ones to that could come up that you might need to describe are things like recall bias. So if you're doing a, for example, case control study, so you've chosen the people who have the disease and who don't have the disease, and you're asking them to think back about whether they had a specific exposure. If you take someone with, MS and say, did you live in a country where you didn't have much sunlight? They might be more likely to remember that because they have the condition. Whereas someone who doesn't have a condition might not think to include that in a questionnaire or something like that. Okay. Um, Things that aren't really included in this table are reporting bias. So the same thing, if someone's filling in a questionnaire and they're asked about undesirable habits like smoking or vaping or whatever, they might be less likely to report it um, on the questionnaire. And this observer bias that's at the bottom can be for treatments, but also for exposures. So here it's saying in the fact that if a researcher knows that they're giving an intervention to someone, they might be more likely to measure a certain outcome. But the same can happen for like case control or cohort studies where if an observer, or sorry, if the researcher believes that a certain exposure leads to a disease, they might be more likely to ask questions that extract that information from them. Um, Fine. Those are the main types. Again, you can look at the table to review. Oh, lead time and length time. Sorry, I should explain. Um, Lead time bias. So these are both to do with the length of time associated with a disease. So lead time is especially important for screening studies, where if you introduce a screening program, you're going to pick up diseases at an earlier stage. And so it looks like people are surviving for longer, but the survival hasn't changed, just they're being picked up earlier, and so they have the disease for longer. Length time is different. So it's comparing diseases that have a long, so it says here, latency period. For example, something that's very chronic, that has a longer course compared to something that would, kill someone quickly. It might look like survival is higher for the top one compared to the second one. All right, I think there are some questions that are just associated with studies. So if you go back to the Socrative, we've got some about study design and bias. And I'll leave the bias slide up because I think that's more confusing. So this first one, a project looking at the association between CKD and long-term NSAIDs. Participants have been divided into two groups based on whether they are on the chronic NSAIDs, and that can be followed for CKD development. I can give it a couple more seconds and then we'll discuss the answer. Okay, brilliant. So most of you got this. So this is a prospective cohort study. The way I differentiate between cohort and case control. Here in this case, the investigators aren't selecting people who have CKD and not CKD. They're instead looking at the exposure primarily, so the NSAID use, and then following up these people to see whether they experience the outcome, which is CKD. Does that make sense? And it's prospective because it's going forward in time. We're following up to see if they develop CKD. All right. And the next one, investigators comparing the efficacy of conservative and operative management. 500 people divided into two groups, 250 in each group, and then they're followed for a couple of years. What kind of study design? Okay, so this one is a randomized clinical trial. So we're recruiting people who have a condition, so acute appendicitis, and then splitting them into two groups. It doesn't have to be placebo versus intervention. It can be two different types of intervention. So here, conservative management, basically placebo and operative. And randomly assigned means that it's a randomized trial. Okay. So it's about type of bias. So a medical center has developed a biomarker that can be used for ALS screening. They decide to offer the test to all patients aged over 50, and then subsequently they determine that following the introduction of the test, survival of ALS patients has increased by approximately 2 months, which could explain this finding. Okay, so this one is lead time bias. Here we're looking at, they're saying that for one disease, the survival has increased following the introduction of a screening test. And so the screening test is just detecting the fact that people have ALS about 2 months earlier. And so it appears the survival is prolonged. Um, just to recap, length time bias, which some people have selected, is again, it's more about the course of the disease. So a screening test is gonna comparing two diseases. the introduction of a screening test will mean that something with a longer or more indolent course is going to appear to have longer survival, whereas the disease that gets symptomatic quickly will not be picked up by that screening test. Because as we said right at the beginning, the screening is just for an asymptomatic population. Yeah, and the next one is also a type of bias. So a clinical trial um, done to assess the effectiveness of a new statin. Patients randomly divided into two groups, and one with the new drug, and the other with atorvastatin. Neither the participants nor the researchers know who's getting the new drug, and such an approach best prevents which of the following biases. Okay, brilliant. So most of you have got the correct answer. This is observer bias. Um, Observer bias is where they're talking about the fact that it's blinded, so neither the participants nor the researchers know which one is getting which treatment. If they did know, so if it's not a blinded trial, then the investigators know who's getting one and they are more likely to report outcomes in a population that's getting a new drug, for example. Some people have selected selection bias. Selection bias is about whether so in a clinical trial like this, whether the randomization is appropriate or whether the study population properly represents like the full population in something like a case control trial. Sorry, or a cohort trial. So here it doesn't really talk about how it does say that they're randomly divided. It's not asking about, whether the participants' characteristics are matched, things like that. So it's hard to tell, I appreciate, which one it's asking about. Here, I think it's the blinding that is the aspect that they're questioning. I think there's no, sorry. Let's discuss quantifying risk and then we can move on to this question. Okay. So again, a concept that I found kind of hard to wrap my head around, but there are three types of studies that we've discussed and three different risk measures that we can use. So starting with cohort studies, where we're looking at, if people were exposed to something and then if they go on to develop an outcome. So the first measure that you might be able to calculate or discuss with a patient is relative risk. It's pretty much what it says on the tin. So it's the risk in the exposed group divided by the risk in the unexposed group. And so this is a ratio. So if you're explaining this in words, you're saying, you're 3 times more likely to develop lung cancer if you smoked compared to if you didn't smoke. And 3 times indicates that you're dividing in that sense. Attributable risk is the absolute difference in risk. So let's say you've calculated a risk for the smoking group as 10% and the risk for the non-smoking group as 2% for lung cancer. You're just doing 10 minus 2, and the attributable risk is 8%. Essentially, the proportion of lung cancer that you can attribute to smoking, the exposure. Okay. Number needed to let's just say harm. It depends on what the exposure is, if it's an intervention or if it's a risk factor. So number needed to treat slash harm is 1 divided by the attributable risk. When you're calculating risk, it should be in like a proportion or a percentage. Fine. For things where you're doing an intervention, so you're reducing the risk of the outcome, then you have different measures. So first, the absolute risk reduction. Anything that says absolute is just like taking away, not dividing. Um, so difference in risk for the intervention arm compared to the control arm. And then number needed to harm is 1 divided by the absolute risk reduction. Okay. And then for case control studies, so we can't use risk in that we can't divide by the total population because you're deciding, or the investigator decides how many cases and how many controls you have, right? Um, and so instead we have to calculate odds. And you can remember how we calculate odds in the same way that we talk about odds for like games. You don't say you have, a 3/5 odds. You'd say you have 3 to 2 odds of winning. And it's the same here. So you're doing the odds of the exposure, which is going to be, um, smoking and lung cancer divided by not smoking and lung cancer. And all of that divided by the odds of exposure among the controls. So smoking, no lung cancer, divided by smoking and lung cancer. Um, Essentially, when you're calculating odds, you're not going to be adding things together. You won't have a total population in the denominator ever. You're just doing like smoking versus non-smoking in both groups. And then for when you're explaining things, if the odds ratio is 1, it means that there's no, um, like the exposure doesn't affect the outcome. If the odds ratio is greater than 1, it means that the odds of exposure are greater in the cases. Um, and so it's like when you're explaining that, it's true the other way around. So you're not going to say you're more likely to have been exposed to smoking if you have lung cancer. You can explain this as um, you're more likely to develop lung cancer if you have smoked. Okay. Hopefully the questions will explain this a little bit more. So question 9 talks about calculating odds ratio in this case controlled study. The answer options are a bit mean, so it might help to have some paper and write out what your calculation is using the formula on the screen and then rearrange it to get your result in this format. So it's looking at alcohol use in pancreatitis, and it's given you like a quadrant, so alcohol plus pancreatitis, alcohol plus no pancreatitis, and no alcohol pancreatitis, no alcohol, no pancreatitis. So to get started with this question, let's think about the cases first and then do odds of exposure within those cases, and then look at the controls, so no disease, and then the odds of exposure within those controls. Okay, perfect. So if we start with the cases, so these are the people who developed pancreatitis. Alcohol users is 60, divided by the alcohol non-users is 40. So 60 over 40 for the odds in the cases. And for the odds in the controls of having used alcohol, um, 30 over 70. And when we divide those and rearrange, it's 60. It ends up being 60 times 70 over 40 times 30. And then this one is asking about which of those measures that we talked about is relevant. So, a 68-year-old woman has been diagnosed with pneumonia caused by COVID. She's extremely worried about dying from the disease and asked the physician how likely she is to survive. And so, which of these measures is she most interested in? This isn't something we've directly discussed, but they might throw you some random ones in the exam. They had a couple for us. Okay, perfect. So this is case fatality rate. Here the denominator is the number of cases, total number of cases, and the numerator is the mortality from these cases. Um, all of these other things are to do with, the observational or interventional studies that we talked about. So they don't apply here. Oh, let's talk about statistics before we move on to the next questions. I'll keep this really brief. The key things you need to know about are type 1 and type 2 error, confidence intervals, and basic statistic tests. Firstly, type 1 and type 2 error. You can think about this as type 1 error being false positive, type 2 error is false negative. Um, the way that I remember is just that I think of positives first before the negatives, and so type 1 and 2. Um, when we talk about false positives, it's essentially like rejecting the null hypothesis where you shouldn't have. Um, Fine. And we can also, you might see in the question that it's described as an alpha error, type 1. Type 2 error is a beta error, and it's related to the statistical power of your test, which means that to reduce the chance of a type 2 error, so false negative, we can do things like increasing the sample size or increasing the expected effect size. So if you expect an intervention to cause a really great reduction in like mortality or something, you're less likely to have a type 2 error. Okay. For confidence intervals, once you have a mean, usually it's a 95% confidence interval. Um, the thing you need to know when explaining this is that if we did this test 95 times, or if we did the trial 100 times, 95 times the true mean will fall between this range. Um, the other important thing for confidence intervals is if it spans zero, so if it's going from negative to positive, then the the difference is not significant. So whatever difference you find in risk is not significant statistically. Here's a list of tests. Um, it's not really as complex as it seems. So just t-test is for two groups. ANOVA is for means of three groups. And then chi-squared and Fisher's tests are for percentages. So t-test and ANOVA for means. These are the two for percentages. And this correlation coefficient, obviously for correlations between two continuous variables. I think a thing that threw me at the beginning was that the value of the number, so going from 0.4 to 0.8, isn't how steep the curve is or how steep the line is. It's got nothing to do with the actual values themselves. It's about the strength of the association. Um, let's just go through the three more questions and then really briefly we'll discuss that OSCE station. So here they're looking at the association between smoking and a type of lymphoma. They determine that the relative risk is 1.12 with the following 95% confidence interval, 0.98 to 1.18, which of the following conclusions is correct. Okay, so let's discuss this one. So here, it's asking about confidence intervals. So if I go back to that slide really quickly. um, Sorry, I can't. There we go. Okay. Um, so here we were looking at whether this is a significant value. So the relative risk is between 0.98 to 1.18, they're saying 95% of the time if they do this test several times. Here, the sort of zero value is one, essentially that the relative risk is not greater if you smoke. Does that make sense? If you're dividing the risk of lymphoma in smokers versus non-smokers and you get your answer to be one, that means there's no difference. Does that make sense? And so here, because this interval spans one, that's our new baseline, and this means that there's no significant association. Let's look at the other answer. So some of you have said in some patients smoking increases, while in others it decreases the risk of mantle cell lymphoma. We can't make that conclusion based on just because it's, above and below one. Um, and some of you said smoking increases the risk. So if we look at the relative risk that they've got, 1.12, that would imply that. But looking at the confidence interval, um, because it spans one, we can't. In a case control study, 200 patients with lung cancer compared to 200 controls, and the calculated odds ratio is 5.5, and they've given you this confidence interval. What's the correct interpretation? Okay, lovely. So this is a bit more straightforward. There's a 95% chance that the true value is between 3.8 and 3.2, 7.8. And here they're looking at a new drug in patients with hypertension compared to an original drug and found that on average reduced BP by this value. Um, and look at the confidence interval. And despite these findings, the drug has not replaced amlodipine. Okay, nice. So again, a slightly mean question because if we compare it to the one I had a couple slides ago about confidence intervals. Um, so with the last one, we were looking at relative risk. And in that case, relative risk of one is sort of our null hypothesis, the fact that there's no difference between smoking and non-smoking, right? Here we're looking at the reduction in blood pressure. And so our null hypothesis here is that the reduction is zero. Does that make sense? Um, and so if we look at our confidence interval, 0.9 to 2.6, that whole range is above zero. So essentially it's saying that 95% of the time there is a reduction um, between these two values. Hopefully that explained the difference between this one and last one, where I said our baseline middle value is one. So we have to look at what the mean result is when we're deciding whether the confidence interval relates to statistical significance. So now we've decided that this is statistically significant, but they're not using the drug. And here it's reducing blood pressure by like 1 millimeter of mercury compared to amlodipine. There's no point introducing something different, right? This is not clinically significant. All of these questions have been a bit like hateful. They shouldn't be this crazy in the exam, but I'm giving you harder ones so you're not thrown in the actual exam. And the same with the OSCE stations. Okay. Um, so really briefly, feel free to go if you need to, by the way. I know it's run over a bit. Um, but the station, Miss Ahmed, 52-year-old, has been told she took part in a trial showing that a new medication reduced her risk of a second heart attack. Um, the trial reported this relative risk reduction of 30% compared to placebo, and it's given you this interval and asks you to explain. Um, so firstly, we have to explain what relative risk reduction is. Um, for all of these like percentages, they tell us that when we're speaking to patients, it's nicer to, instead of talking in like chance and percentages, we can give them an absolute number of people and say how many people are affected. So let's say that the original risk of having a second heart attack is 10 in 100 patients. Then if you're taking this new drug, then this will result in, instead of 10, 7 in 100 people to have had, sorry, the second heart attack. And then if we explain the confidence interval, if she asks, we're saying that if this trial was done, 100 times, then 95 times the reduction in risk will be between 10 and 50%. And so we can be confident that it is a beneficial drug because this whole confidence interval is greater than like zero. But it's just like a wide range of how beneficial it is. Okay. So that's it for this lecture. It was a bit muddled, but hopefully it sort of makes a bit more sense now. Overall, don't be too stressed about this. It's quite low yield in both the AKT and the OSCE statements are unlikely. But I'll send the slides and the questions, and you can find the recording up later. Yeah, thank you very much.